I'm Dr. Pete Snyder. I'm the Senior Vice President and Chief Research Officer for the Lifespan Hospital System, which includes Rhode Island Hospital and the Miriam Hospital, Newport, Bradley. And I am also a professor of neurology at the Alfred Medical School. I am a researcher who is focusing on Alzheimer's disease, and I'm particularly interested in early detection. I'd like to identify individuals who are at high risk for disease many years before the onset of symptoms, so that as we develop new therapeutics that might slow the progression of the disease, we can protect quality of life for as long as possible. That's really the most important thing. There's a lot of activity now in developing new therapeutics that may slow progression of the disease. But the thing that is really important to remember is that we're probably not talking about a single disease. It's more like a constellation of symptoms or changes that take place with different causes, but a final common pathway or a funnel that you end up falling into. And so depending on the individual cause that we may be identifying for different patients, there may be different kinds of treatments. So there's not going to be one magic white pill that treats all Alzheimer's disease. We're also not at this point expecting that we're going to find a definitive cure. What we really want to do is slow progression. And if we can slow progression by a good number of years, then that would be a major success. That would change the lives of hundreds and hundreds of thousands and then millions of people over time. And that's what we really want to do. I think we're making a lot of progress. I am guardedly optimistic. We have many, many companies and labs in academia as well that are working on new treatments. But these treatments are potentially going to be costly. They're going to be ones that carry risk. Just about everything we take that's a medicine carries the risk of side effects or adverse events. And so we have to be able to identify who really needs these interventions and who's most likely to benefit from them. So it becomes a chicken and egg problem. How do you know who needs it when they're not really complaining yet, but if that's when we really want to be intervening is early before the symptoms are changing your life. There's both positive and negatives with respect to how we treat Alzheimer's in the state of Rhode Island. We have a rapidly aging population. I think everybody's aware of that, both nationally and locally in this state. We are very fortunate in that we have a fantastic medical school. We have the University of Rhode Island, which is building basic research capabilities in neurodegenerative diseases very quickly. We have two different hospital systems, each with a memory disorders program, one at the Rhode Island Hospital, one at Butler Hospital, that really are taking on the lion's share of the work of identifying individuals early in the disease course and then following them until the middle to end stage when they go into transitional living arrangements. So we have services in place. We have good clinicians in place. What we don't have is a well-connected system where these silos, these two different hospital systems and two different universities and medical school are really coordinating efforts carefully enough to make sure that people aren't lost in the cracks and that our patients and their caregivers understand really who best to turn to, why and when, and what are the options available to them in a coordinated fashion. So Lieutenant Governor Roberts and Director Taylor for the Division of Elderly Affairs a couple years ago launched a state planning process for Alzheimer's disease to map to the national strategic planning process that occurred. And last year we came out with a very detailed plan that I think is very forward-looking and comprehensive, and now it's up to our legislators to pay attention to that plan and devote the resources needed to carry it out. One of the recommendations, which is really a modest one, is to convene a research conference to tie all these pieces that I mentioned together so that we are able to speak in one room with each other and coordinate what our priorities are in terms of collaborating on research and making sure that patients and families are aware of the clinical trial opportunities that are available. And that's going to happen in March. For the first time, we are having a State of Rhode Island conference that'll be tied to the Alzheimer's Association's Caregiver Conference on March 5th. I think In most of my research, the patients I see in my own work are individuals who are often the caregivers for their parents, and they are facing the possibility of the disease themselves. So these are individuals in their late 50s or early 60s, many of whom have some subjective concerns, worry that they may have some changes that are noticeable to them. They may have genetic risk markers for the disease. So for a variety of reasons, they fall into a higher risk group. And what I have found is that one of the scariest parts of this process is a feeling of isolation, of being alone, where you're certainly surrounded by loved ones, family, and support, but you're still isolated because the idea of going through this process is so disconnecting. It's a psychological process that is very traumatic. Those of us that make a career out of studying this disease often refer to Alzheimer's disease as not being a disease for the patient, it's a disease for the caregiver. The caregivers, by and large, have their lives completely disrupted. They are impaired in their ability to pursue their own vocations, to care for their other immediate family, including their own children, as effectively as they would want to. And there is increasing literature showing that caregivers' own health is adversely affected in very substantive ways. And I don't just mean psychological health, I also actually mean medical health, in that many caregivers go without taking care of their basic medical needs and attending to their own health concerns because they're so focused on caring for their parents usually. When we look epidemiologically at the scope of the problem, and we look economically at the impact on our society for failing to identify a cure and provide an intervention that slows the progression, we have to look at both groups. And so we talk about 50 million people by 2050 will be affected by the disease, but you can at least double that in terms of the number of people affected by the disease, including the caregivers. So yes, the scale is tremendous. What we're learning is that individuals who have several lifestyle risk factors are likely to progress a little more rapidly. Okay, those include diabetes and other metabolic diseases, cardiovascular illness, long-standing cardiovascular illness, hypertension, and high cholesterol, untreated cardiovascular change, obesity, head injury, traumatic brain injury. Another risk factor is untreated depression and stress. We have lots of soldiers returning from fields of war with post-traumatic stress disorder. These are individuals who are also at higher risk for Alzheimer's later in life. So treating depression, treating chronic anxiety effectively, maintaining adequate body weight and cardiovascular health, these are things that are going to provide some protective benefit in terms of later onset disease. I would argue that in this country at this time, the standard of care, appropriate care, is to have accessible to you clinical trials for novel treatments should you qualify to be in one of those studies. I work at an academic medical center where we have lots of clinical trials for many diseases, not just Alzheimer's disease. And part of the reason it's important to me to be working at an academic medical center is because I believe that it is at centers like this that we are able to provide what is truly state-of-the-art care, which includes access to experimental therapies. We don't have a therapy yet that slows progression of the disease, although again, I'm hopeful that we'll get to one. Right now we have some modestly successful symptomatic treatments, but patients and families are going to benefit most from our advances in science by being cared for at a center where they have access to clinical trials. As we know, this is a very long, insidious disease, and it takes its time, and it's a grueling process. And what we really want to do is understand the entire natural history of the disease, and different therapies may may have differential impact at different stages. So we really need to be studying individuals at all stages of the disease, and there are different questions at each stage that are more relevant. So some of the more home health care, transitional safety issues are more germane at one stage of the disease than another stage of the disease. But in terms of identifying treatments that may slow progression, we can't wait till people are at the end stage, because if, as you can imagine, by the time someone gets to that stage, the damage has been done. We're not going to resurrect dead cells. What we need to do is protect the tissue, protect the brain, while it still has potential to be protected to maintain its overall health, and that means intervening early. So we need people to engage with us in clinical trials while they're still in the workforce, while they're still caring for their parents or their children, while they're still not yet succumbing to the ravages of the disease, because these are people who are really, really valuable.